Gastrointestinal stromal tumors, GISTs, overview. Gastrointestinal stromal tumors, GISTs, are the most common mesenchymal tumors of the gastrointestinal tract, primarily driven by mutations in the KIT or PDGFR genes. The management of resectable GIST involves surgical resection as the cornerstone of treatment, often combined with adjuvant or neoadjuvant therapies to reduce recurrence risk and improve survival. Intraperitoneal therapy in GIST. Intraperitoneal (IP) therapy involves the direct administration of therapeutic agents into the peritoneal cavity, targeting microscopic residual disease after surgery. This approach is more commonly explored in other malignancies, such as ovarian cancer, but has limited applicability in GIST due to its unique biology and reliance on systemic therapies like tyrosine kinase inhibitors, TKIs. However, IP therapy could theoretically serve a role in GIST by delivering 1. Chemotherapeutic agents. While GISTs are generally resistant to conventional chemotherapy, IP delivery might be considered in cases with minimal residual disease. 2. Biologic or molecular agents. Localized delivery of biologic agents such as monoclonal antibodies or small molecules targeting KCUT PDGFR mutations might be explored in experimental settings. The clinical evidence supporting IP therapy in GIST is minimal, and systemic TKIs remain the primary molecular approach for adjuvant treatment. Molecular therapy in the adjuvant setting. Molecular therapy plays a pivotal role in the management of GIST, particularly in the adjuvant setting. These therapies target the aberrant tyrosine kinase signaling pathway resulting from KIT or PDFRA mutations. Approved molecular agents. 1. Imatinib, Gleevec, the first-line adjuvant therapy for resectable GIST, shown to improve recurrence-free survival, RFS, and overall survival, OS, in patients with high-risk GIST. Typically administered for 3 years post-surgery for high-risk cases, based on data from the ACOSOG Z9001 and SSG-AIO trials. Mutational analysis is crucial to determine sensitivity, as PDGFRA D842V mutations are resistant to imatinib. 2. Sunitinib, Sutent, used in imatinib-resistant or intolerant cases. Primarily employed in advanced or metastatic GIST, but may have limited application in adjuvant settings for specific mutations. 3. Ripretinib, Kinloch, approved for advanced GIST after failure of prior TKIs, under investigation for earlier stage disease. 4. Avapritinib, Avakit, effective in GISTs with PDGFR D8842V mutations, which are resistant to imatinib, primarily used in advanced disease, but could have adjuvant applications in select cases. Advantages of molecular therapy. Targets the molecular drivers of GIST, minimizing systemic toxicity compared to traditional chemotherapy. Significantly improves outcomes in high-risk cases. Challenges: primary and secondary resistance to TKIs. Side effects, including fatigue, edema, and hepatotoxicity, which may impact compliance. Scope of neoadjuvant tyrosine kinase inhibitor, TKI therapy in GIST. Neoadjuvant therapy refers to treatment given before surgery to shrink tumors, making resection more feasible or reducing the morbidity associated with extensive surgical procedures. Role of TKIs in the neoadjuvant setting. 1. Tumor downsizing. TKIs such as imatinib are effective in reducing the size of large or anatomically complex GISTs, enabling less invasive surgery. 2. Organ preservation helps preserve critical structures, e.g. sphincters or vasculature, that might otherwise be sacrificed in a more extensive resection. 3. Facilitation of complete resection increases the likelihood of achieving R0 resection, complete tumor removal with negative margins. Evidence and limitations. Efficacy. Studies such as RTOD 0132, ECRIN 6665 have demonstrated significant tumor shrinkage with preoperative imatinib, especially in KEXON 11 mutations. Duration. Neoadjuvant TKI therapy is typically administered for 6 to 12 months, with response monitored by imaging. Challenges. Risk of progression during therapy or resistance development requires careful patient selection and close monitoring. Future directions. 1. Combination approaches. Exploring combinations of TKIs with other agents, e.g. immune checkpoint inhibitors, to enhance efficacy. Investigating the role of localized IP delivery of molecular agents. 2. Liquid biopsy and biomarker studies. Identifying circulating tumor DNA, ctDNA, or other biomarkers to guide therapy and monitor response. 3. newer TKIs and novel agents, development of next-generation TKIs with broader activity against resistant mutations, evaluation of adjuvant, neoadjuvant roles for drugs like ripretinib and avapritinib. 4. Personalized therapy, mutational analysis, and individualized treatment plans to optimize outcomes. Conclusion. While intraperitoneal therapy has limited application in GIST due to its systemic nature and reliance on molecularly targeted therapies, molecular approaches, particularly TKIs, remain central to adjuvant and neoadjuvant strategies. Continued advancements in molecular diagnostics and therapeutic development will further refine the management of GIST and improve patient outcomes.